Hello everybody. In this video, we'll discuss about endodontic emergencies. First, we'll see how endodontic emergencies can be defined. According to Walton and Fouth, endodontic emergencies can be defined as occurrence of severe pain and or swelling following an endodontic treatment appointment requiring an unscheduled visit and active treatment. According to Grossman, an endodontic emergency is defined as pain and or swelling caused by inflammation or infection of the pulp and or periradicular tissues necessitating an emergency visit to the dentist for immediate treatment. According to Cohen, an endodontic emergency is defined as pain or swelling caused by various stages of inflammation or infection of the pulpal or periapical tissues. Moving on to the classification of endodontic emergencies, first classification is a classification given by Gutman. According to Gutman, endodontic emergencies are classified as treatment of vital pulp, treatment of non-vital pulp, and aesthetic emergencies. Under treatment of vital pulp, Grossman has included acute reversible pulpitis, hypersensitive dentin, recurrent decay, recent restoration, and cracked tooth syndrome. And under treatment of non-vital pulp, he has included active apical periodontitis, necrotic pulp, acute alveolar abscess, phoenix abscess, acute irreversible pulpitis, localized and non-localized. The aesthetic emergencies mentioned are fracture of crown, fracture of root, owl's tooth. Now, next would be the endodontic emergency classified by Grossman. Grossman has classified endodontic emergencies as pre-treatment, during treatment, and post-treatment emergencies. Under pre-treatment emergencies, there are dentin hypersensitivity, pulpal pain, which could be symptomatic reversible pulpitis, symptomatic irreversible pulpitis, acute pulpitis with apical periodontitis, acute apical abscess, cracked tooth syndrome, traumatic injuries. And during treatment, it was hot tooth, exposure of pulp, fracture of root or crown, flare-ups, hypoaccidents, and tissue emphysema. Under the post-treatment, high restoration, over-obturation, and under-obturation. I want everyone to note that this is a conventional endodontic emergency classified by Grossman, originally by Grossman. However, the present Grossman book has been given with a newer classification. The newer classification is not given by Grossman by himself. It is based upon the discussion held in the year 2020 by the American Association of Endodontics. According to the newer classification, which is given in Grossman's 14th edition, the endodontic emergencies are still classified as before treatment, traumatic injuries, before treatment, during treatment, and after treatment. However, certain elements during treatment has been eliminated in the newer classification. They thought that the emphysema and hypoaccidents are mishaps and not an endodontic emergencies. So here, according to the newer classification, under before treatment, there would be endodontic emergencies presenting with pain and or swelling, the crown originating fracture, which was previously known as cracked tooth syndrome, we no longer use that term, symptomatic reversible pulpitis, symptomatic irreversible pulpitis, primary symptomatic apical periodontitis, secondary symptomatic apical periodontitis, or acute exacerbation of asymptomatic apical periodontitis or phoenix abscess, symptomatic acute alveolar abscess, cellulitis. Under traumatic injuries, it would be crown root fractures, luxation injuries, tooth avulsions, and during treatment, it would be hot tooth, endodontic flare-ups, and after treatment, it is only post-obturation pain and vertical root fracture. So this is the latest classification given in Grossman 14. Now we'll go into detail about each endodontic emergencies. The first endodontic emergency is dentinal hypersensitivity. We all know that there are a lot of concepts on dentin hypersensitivities, which is given as the theories of dentin hypersensitivity. But however, there is a recent updates from the year 2021 regarding the theories of dentin hypersensitivity. The conventional concepts were the the hydrodynamic theory, or rather we call that as a classic hydrodynamic theory, direct intervention of dentinal tubules, neuroplasticity and sensitization nociceptors, odontoblasts serving as sensory receptors, and algoneurons. Now the newer concept that has been introduced are, as I mentioned, the neuroplasticity theory, which is given by Nari et al., and the algoneurons theory, which is given by Fried et al. According to neuroplasticity theory, the C fibers causing inflammation alters the sensitized nerve fibers, making the nerve fibers more sensitive to smaller fluid shifts, resulting in neuroplasticity, and this neuroplasticity will lead to cause newer nerve sprouting or nerve nerve growth factors release, leading to hyperalgia. The next theory is algoneurons theories. According to this, the neurons respond to sensory effect of efferent signals. Both the A and C fibers are low threshold mechanoreceptors, and as its cell body has cytochemical markers similar to LTMS. The high threshold nociceptors becoming LTMS leads to peripheral and central sensitization, leading to A fibers evoke tactile allodynia under central sensitization. So these two theories are included on the current concepts of dentin hypersensitivity, mainly the algoneurons theory, which is given by Fried et al., has to be written in this form. Now, speaking about the sequelae of pulpitis, the first would be the symptomatic reversible pulpitis. Here, there would be mild to moderate pulpal inflammation caused by noxious stimuli. The pulp is capable of returning to normal once the stimuli is removed, and here the treatment would be to remove the noxious stimuli and restoration if required, and periodic vitality tests as required. Then symptomatic irreversible pulpitis. Here, symptomatic pulpal inflammation and pulp is incapable of healing. Then in primary symptomatic apical periodontitis, there would be painful periodontal inflammation due to trauma, irritation or root canal infection would be present, and clinically there would be pain during biting and percussion. However, the treatment remains same for both these clinical conditions, which would be pulpectomy and pharmacological management for the pain. The next would be the phoenix abscess, or rather the secondary symptomatic apical periodontitis. The acute inflammatory reaction superimposed on an existing asymptomatic apical periodontitis. Now, the next would be the symptomatic or acute alveolar abscess, which would be rapid inflammatory reaction. There would be tenderness to the tooth, pus formation would be present, and the swelling of associated tissues. And in finally the cellulitis, there would be symptomatic edematous inflammatory process that spread diffusely throughout connective tissues and facial planes. The pharmacological management along with the following is required for these clinical conditions. First would be the occlusal adjustment following access opening, IND, needle aspiration, antibiotic dressing, and if required, trephination and decompression. Now the management, first the endodontic preparation is initiated with appropriate intracanal medicament. Then systemic non-steroidal anti-inflammatory drugs is prescribed to the patient, and if the patient has cellulitis, then ceratopeptidase. Systemic steroids are recommended, and systemic antibiotics are recommended to the patients only in case of systemic illness. Unless and until the patient develops any kind of systemic illness, antibiotics are not required. This is as per the present guidelines given by American Association of Endodontics. And finally, In case if you're prescribing steroids, make sure that the patient is not diabetic, which means you have to you have to do a proper blood sugar profile, and if the patient is on the higher side, maintain the blood sugar level with adequate insulin treatment before starting steroids. Then another important note while you're prescribing non-steroidal anti-inflammatory drugs would be with ibuprofen, where it is contraindicated in case if the patient is going through any respiratory disorders, as ibuprofen is a strong bronchoconstrictor. So, though ibuprofen is a drug of choice for pulpal pain, so make sure you ask the patient whether he or she is having a history of respiratory disorder before prescribing this drug. The another important, most commonly missed out point while prescribing non-steroidal anti-inflammatory drug is the history of patient, whether he or she is consuming any blood thinners. In case if the patient is on blood thinners, please don't give any kind of non-steroidal anti-inflammatory drugs, because the non-steroidal anti-inflammatory drugs elevates the prothrombin time, and thereby it is a strict contraindication for the patients on blood thinners. So in that case, you can simply prescribe the patient with 500 milligrams of paracetamol or 650 max. So if you need to know more about the management of these clinical conditions, you can go through Endodontic Principles and Practice by Mohammad Torabin Ajad, and the Cohen's Pathway of Pulp, the 12th edition. Now, another few updates on this topic would be the CTS, or rather the cracked tooth syndrome. We no longer use the word CTS or cracked tooth syndrome. So instead, we use the newer term called as crown originating fracture. The reason is that once we assume that there is a crack on the tooth, that does not mean that it is a syndrome, it is just a crack. So hence it is the terminology is phased out. So the newer terminology that you need to remember is crown originating fracture, which is abbreviated as COF. So this is incomplete fracture of the tooth with vital pulp. So this is again given in detail in Grossman's 14th edition Endodontic Practice, where the updated terminologies are there in the Endodontic Emergency chapter. Now, as briefly we'll speak about how the cracked tooth syndrome, or rather presently the crown originating fracture or COF, can be diagnosed. It could be we can start the diagnostic procedure with percussion, followed by probing, bite test, and with application of methylene blue. The bite test is the confirmative diagnosis for the crown originating fracture. So on the bite test, the patient would not be having pain while biting. Rather, the pain would be elicited on the release of bite force. So this is a classic way of differentiating cracked tooth or rather the crown originating fracture with that of apical periodontitis. Another common way is by using trans-elimination or under magnification with either loupes or dental operating microscope. A combination of first dyeing the tooth with methylene dye and then observing under magnification also helps for an accurate diagnosis of COF. Radiographically, COF can be diagnosed with CBCT, but then again there is a pinch there. The the CBCT can be used to diagnose a COF only if the fracture line of crack is more than 120 micrometer. So which means if it is less than 120 micrometer, you cannot find a crown originating fracture with a CBCT. Now, management of crown originating fracture. First and foremost, we have to give a sedative cement over the exposed dentin, followed by stainless steel banding, selective grinding, especially on those marginal ridges, and if pulp is exposed, we can go ahead with pulpectomy and a full coverage restoration after removal of the band. Now this is a filler topic. It's an it is a mishap where the file has been stuck during a cleaning and shaping procedure. So this is also for me, it is an endodontic emergency. So this can happen especially if your endomotor run low on torque and your file gets stuck, or sometimes the endomotor goes out of charge. Again, the file might get stuck. So in this case, you can detach the endomotor, remove it, and you can use a forceps or a artery forceps or a plier to and rotate it anti-clockwise or clockwise based upon what the file is and the cutting mechanism is, and unwind it and take it out. Or if you have an backup endomotor, use the backup endomotor, unwind it and remove it. Now, coming back to the topic, endodontic emergencies, the next emergency would be the traumatic injuries. The traumatic injuries, mainly we have the crown fracture. So in the crown fracture, we have to see whether there is loss of tooth structure or if there is no loss of tooth structure. If there is no loss of tooth structure, we have to check for the dentin. If there is loss of tooth structure, we have to check for the dentin, and we have to see whether the dentin is involved or not. If the dentin is involved, we have to check whether pulp is exposed or not. So there are a lot of things that we need to go into the traumatic injuries. So all these traumatic injuries and its updates and guidelines and the management of traumatic injuries and fracture, especially the fracture and luxations, you can go through this article, the guidelines, which are the IADT guidelines, which is given in the year 2020. There is another updated IADT guidelines which is given in the British Dental Journal. So though they say it's an updated, it is not the original IADT guidelines. It is something and adapted towards the British population. So I recommend you all to go ahead with the IADT guidelines given in dental traumatology in the year 2020. Then another important aspect of the as far as the owl's tooth management is concerned, the medium. So as of now, milk, HBSs, patient saliva and saline are considered to be gold standards, and the splinting mechanism would be to splint the tooth in case of avulsion, keeping after the tooth being placed in the socket. The splinting should be done with a nylon line or composite. So the reason why we keep these flexible splint is to promote periodontal and pulp healing, and the duration for splinting should be about 2 weeks. And note that the tetanus booster should be given to the patient before the patient is discharged from your dental office. The other such guidelines and updates are given in the International Association of Dental Traumatology guidelines for the management of traumatic dental injuries, avulsion of the permanent tooth. So this is again an IADT guidelines given in the year 2020. So the next emergency or during treatment emergency would be the hot tooth. So though it is the during treatment, we are actually have not initiated, we normally never initiate the endodontic treatment if there is this kind of clinical condition. So the hot tooth, so there is some theories associated with the hot tooth. Starting from the location, the local tissue changes because of the inflammation. Then there would be hyperalgia because of the patient would be nervous, and the central core theory that you need to go through, and the most important theory, the TTXR theory or tetrodotoxin resistance theory. So we'll speak more about the tetrodotoxin resistance theory. Now the tetrodotoxin sensitive normally the pulp should be tetrodotoxin sensitive, or the class of, now this is the class of sodium channels in the C fibers. Now, the neuroinflammatory reaction converts the TTXs, the tetrodotoxin sensitive, to TTXR, which means tetrodotoxin resistance. These sodium channels will be resistant to lignocaine. To TT, so it is said that the TTXR is 5 times more resistant than TTXS. So, in short, there would be if in case if it is TTXS, which means the pulp is sensitive to lignocaine and the pulp tissue can get easily anesthetized. Pulpal anesthesia can be achieved for such patients easily. In case the TTXS is converted into TTXR, especially because of the neuroinflammatory reaction, then in that case the lignocaine would be resistant to achieve pulpal anesthesia. In that case, the management should be done with 4% atricane with 1:1 lakh epinephrine IANB about epinephrine. In case if you are giving inferior alveolar nerve block, please make sure 3.6 ml of 4% atricane should be deposited for achieving proper pulpal anesthesia. One cartridge is about 1.8 ml, so we require 2 cartridges of 4% atricane to achieve proper pulpal anesthesia in hot tooth. So all the updates on the strategies for the patient with a hot tooth is given in DZNA 2010. Then the pain after, now this is again a filler topic, the pain after placement of intracanal medicament. So this is usually a pressure pain and this has to be relieved before you before you discharge the patient from your dental office. So first and foremost, this is based upon a single seal technique where after placement of an intracanal medicament, cotton pellet would be placed on your pulp chamber and then temporizing with a temporary cement. Once this is done, and especially when you're condensing the temporary cement, there would be an increased pressure formed within the pulp chamber. So this pressure should be released, and this can be done using a straight probe. And once the pressure is completely released, use a wet cotton pellet and wipe it off on the occlusal aspect of it and seal the exposed poke. This could help to release all the pressure buildup within the pulp chamber and seal the pulp chamber as well. So this is just a clinical tip while you place an intracanal medicament. Now coming to the next topic, the anaphylaxis. Anaphylaxis, though it is not included in endodontic emergencies, I personally find that it is the most important emergency that we all should be prepared for in a dental office. So first and foremost, we need to understand when the patient is going through anaphylaxis. So there are some clinical features, key features, which indicates that the patient is going through anaphylaxis. First, there would be constriction and tightening of the airways. Then the patient would experience trouble breathing or swallowing. Then there would be severely swollen lips, tongue and throat. There would be shock with severe drop in blood pressure, and most often the patient would feel chest pain, rapid pulse, or weak or uneven heartbeat. And also, the patient will be feeling weak, confused, light-headed, or passing out. So all these things would happen in less than 1 minute. So we have to be very careful while you're dealing with anaphylaxis. We have to be so alert, and especially this will happen while depositing local anesthesia. So the management here would be 0.5 ml or 0.5 milligram of 1:1000 epinephrine IM, especially at vastus lateralis, every 3 to 5 minutes until the patient recover. So also we need to have a crash cart with all the emergency drugs required in the dental office. If this is tough, you can also use an EpiPen for the management of anaphylaxis. So this is this kind of the EpiPen is So the EpiPen is an auto-injectable device that delivers the drug epinephrine in the same concentration as I mentioned before, and here it is mainly an auto-injector. So you just have to stab on the patient. It delivers the exact amount of epinephrine in one dose, wait, and then stab if required until the patient recovers. Then post-endodontic treatment emergencies would be high restoration, over-obturation, under-obturation, and root fracture. We'll end this session with a clinical photograph. This is a patient who reported to our dental office with the chief complaint of a painful tooth in the upper right region of the jaw for about a week. We took radiographs and we planned of performing a root canal treatment as the diagnosis was irreversible pulpitis in relation to 1/6. The patient was scheduled for root canal treatment and local anesthesia was given, a buccal infiltration. While giving the local anesthesia, thoroughly it was checked for any positive aspiration, and absolutely multiple times it was aspirated. It was totally negative before we deposited the local anesthesia. However, still the patient has developed the hematoma. It was quite shocking for us. The patient was rushed to the ER and necessary investigations were performed. While investigating and running the blood routine, we found that the patient is hemophilic. So the patient never had this kind of a history before. This is the first time the patient is coming to the dental office, and he could not recollect any kind of bleeding disorders in his past as well. However, from this we can say that there are a lot of dental emergencies which is associated, and hence for us it is very important to be prepared for all this kind of dental emergencies. So if you want to know about the medical problems associated with dentistry, please go through Scully's 7th edition. Another important note, I would like to conclude this presentation with saying that it's very important for us to understand the current concepts and guidelines how to manage endodontic emergencies, especially when there is an emergency. We should have an immediate solution and a protocol algorithm set to deal with that particular problem. It's not when during the emergency you have to phone a friend or ask a friend of yours and understand what should be done for the emergency. So it is very important that you be prepared. Put in the algorithm for each emergencies. You can put posters how to manage a certain kind of emergency to have a seamless practice. If you have any questions, please mention in the description box and we'll take it from there. Thank you.